That was totally my fault. Okay, I can see it.
Okay.
That was easy.
Right, we've got a 95-year-old female, 2 to 3 days of severe vision loss in the right eye. The left eye lost vision to wet macular degeneration. After having an 8-month gap in therapy between January and September 2020 during
That was a
COVID.
COVID. There's papers written about, yeah, it says, that was a papers written about that COVID gap.
And then the visual acuity was 20/25 in the right eye and hand motion in the left eye. She has diabetes, not on medications, thyroid. She's on artificial tears. She's now hand motion in both eyes. Pressures are normal, and the anterior segment is without any rubiosis, and she's pseudophakic. And here we start with the photographs, if someone wants to describe that one.
All right, so we got color fundus photo. Media looks somewhat unclear. Attention is drawn to diffuse hemorrhaging in all quadrants. The nerve looks relatively normal. Vessels maybe somewhat tortuous where we can see them. And the macula doesn't have maybe the usual foveal reflex. It's a little blunted there. And then again, there's a predominance of hemorrhaging, particularly superiorly and nasally in this view.
I think the arterioles are very attenuated as well. And there's kind of an absence of like cotton wool spots. All right, other eye.
Left eye here, media looks clear, nerve looks within normal limits, and the vessels somewhat attenuated and tortuous again. The macula here has a large amount of geographic atrophy, I guess, a kind of pale appearance to it, and a central, maybe some heme there, subretinal heme there. Essentially, periphery looks mostly normal to me.
I mean, on a color picture, it's fair to use colors too. So you just say it looks kind of red in the middle, a little whitish,
Yeah, whitish.
a little gray around the edges, maybe.
Well, I'm glad you didn't call that nerve pink, sharp, and flat. I mean, that nerve is like white and it's got a very deep cup, but I don't know. All right.
Yeah. Okay, here we have this is IR.
Yeah, OCT. Well, IR on the left.
Yeah, the grade, I mean, yeah, okay, so IR on the left. With looks like a variated dark and white pattern to it. Get the terminology for IR is hyper.
Well, yeah, but on the right, just do the OCT.
Okay.
This is a raster.
That's it.
So just do the OCT on the right.
So the OCT looks grossly abnormal. With like a large amount of intraretinal fluid, gross distortion of the foveal contour.
Looks like a grainy cartoon mountain. You know, she probably has surface disease and a cataract, which aren't helping the imaging here, but we see a lot of elevation, which we assume is probably subretinal fluid.
Yeah, it's tough on this one. I've been burned on these before. So on the raster scans, you can just see what you can see. You can see the front of the retina, you can see the RP a little bit. So there's something there. It could be intraretinal, it could be subretinal. You really need the high resolution images. And I think we couldn't get them in Harmony because she couldn't fixate. So the high resolution images use 100 images and average out the noise. And so this is just a single capture, which is something that's, so yeah, it's not normal.
Okay, same thing with the left eye. Looking at the OCT again, very grainy view. Looks like there's some elevation, but not as edematous. I guess on the left image there, we see again that central pattern of distortion and whiter kind of plaque area.
So on the color, you said that was atrophy, but now that you have the OCT, what do you think might be going on there?
It's more like elevation with fluid. Actually, maybe CNV even under the.
Yeah, probably a scar. Or an old.
I think it's fibrosis.
Yeah, fibrosis. Yeah,
Just kind of a burnt out burnt out degeneration.
Yeah.
We still call it geographic at that time.
No, this one, because there's no atrophy there. You can see the PED
Mhm.
and you can see the outer retina. I guess it's outer retinal atrophy, but it's not far retinal.
This is where a lot of patients would throw in the towel and just say, "Stop sticking me."
Right, appropriately, I think.
Yes.
So here we have FA, early phase, maybe like almost AD phase now. But no obvious leakage or staining. Other than kind of proximally to the vessel, the macula was more hypofluorescent.
Good.
And then some peripheral patches of hypofluorescence. And then actually we see some fronds of hyperfluorescence, again, toward the distal vasculature, hugging the vasculature.
What's a normal AV time? This is at 26 seconds.
Yeah, our time's cut off by my meeting controls, which I hid before, but now I'm afraid to hide them. Hold on, I'll hide them again. No, I can't hide them. Never mind.
Because I think sometimes in this condition, the time's a little delayed.
Yeah, we can't see it. Can you see it? Cut off
It says
on it.
26 seconds.
Okay, that's not too bad. I mean,
It's
for
not too bad.
Ophthalmology.
All right, we're at 31 seconds.
Okay, we're seeing more prominent spots of hyperfluorescence along the vasculature, proximal to the nerve. Again, hypofluorescence noted of the macula, and then peripheral to drop out hypofluorescence noted.
Yeah, that's great.
All right, we're at 1 minute now.
There's I guess more staining since a lot of those spots haven't grown too much, the hyperfluorescent areas, but then also some leakage peripherally. Not seeing too much new there.
So there's two causes of hypofluorescence. Like if you look at this wedge in the macula, it's dark.
Yeah, it's probably blockage from
Yeah, what's your other cause?
vascular filling defect.
Good. So do you think that's one or the other or both?
I like thought well, it looks like it's actually not filling either.
Go back in your mind to the color fundus photo. Was there blood in the macula?
Yes, there was.
There was blood, but
But
there
it was more
was
so peripheral though, so I guess it's, yeah, more of a vascular filling defect here.
Yeah, go back one, Alan. You can. Yeah. No.
There's some.
Oh, that's, yeah, there's some blood, but there's not that much blood posterior to the equator. I mean, it's not contiguous. So if you look at, yeah, that one. So what's that called? The dark areas where there's no filling. Have a word for it.
Drop out.
Yeah, capillary dropout is one there. Okay, I'll take that.
We're at 3 minutes.
Okay, similar appearance, more hyperfluorescence, all along the vasculature, but not peripheral to them.
And now you can see those hypofluorescent patches that really correspond with the hemorrhages in the periphery. Those are blocking.
Yeah, so you have the hemorrhage and the non-perfusion. So we often, it's very common to have an artifact, and this has happened in the last 4 months, where you look at a fluorescein, there's a dark area out to the side that looks like non-perfusion, but it's really just dark because the periphery of the pictures are often dark. This is non-perfusion. So if you can see a line, so I was thinking of capillary non-perfusion, but capillary dropout's good. So if you see a line between the vessels, they're truncated, and then you get all that dark stuff. This is a really good example of non-perfusion.
This is almost 5 minutes now.
Similar appearance, we're seeing non-perfusion, the macula, and then sort of diffuse hyperfluorescence from leakage everywhere else.
Just for fun, the other eye.
Other eye, some hyperfluorescence of that white plaque area, the macula. Otherwise, it's mostly normal. There's some hyperfluorescence, maybe superior to the nerve. Otherwise, it's okay.
This is 5 minutes.
Yeah, sort of the same appearance, just more hyperfluorescence from staining, I think, of plaque.
If it wasn't staining in the middle, what else could it be?
I guess leakage too,
Or-
I think, or a window defect.
Okay. And what do you think, Dr. Cohen? Do you think there's probably some staining and some window defect?
I would call it mostly staining.
Yeah.
I would go mostly, because I think it's a scar and it's just staining. I don't think there's much. There's a window you'd see early on, right? Do you see something very, very first? I mean, the first one's not super early. That's the first one, yeah.
Yeah, it's
Yeah.
1 minute, 1.5 minutes. Yeah.
We focused on the other one, so.
All right. It's a 2-for-1, but we're not going to treat this eye. Okay, so to summarize the findings, you got 360 degrees of blood hemorrhages, attenuation of the arteries, macular edema in the right eye, and large areas of capillary non-perfusion. Dr. Nittman, what is your differential?
Screamed like a central retinal vein occlusion initially, with some blood and thunder appearance, macular edema and diffuse hemorrhaging.
Did you see thunder, sir?
I heard it.
You heard it. Okay, fair.
Otherwise, the AMD it doesn't really look like wet AMD, but she had that severe force in the other eye. Not that much bleeding.
Try to give me at least 2 others for that right eye with those 360 dot blot hemorrhages.
Yeah, severe proliferative diabetic retinopathy.
Great.
Hypertensive retinopathy.
Good.
Severe,
Now, as far as proliferative, as much as there was non-perfusion, would that have been proliferative? There was
no NV of the.
I didn't see any.
It was smart to say severe.
Yeah, severe non-proliferative.
Yes.
If you're hidden diabetic,
non-proliferative.
you're looking at very severe non-proliferative.
Can OIS have that appearance or typically not that many dot blocks?
It usually doesn't look like, ocular ischemic syndrome doesn't look like much. Yeah, so I haven't seen that. Like
Usually
maybe-
it's bigger, fewer mid-peripheral dot blot
Yeah.
hemorrhages, but you could have it on the differential spare.
If it crossed over to that, it would be central vein occlusion. So it'd be changes in the immune system.
All right, let me see. So it was a central retinal vein occlusion. I had like severe non-proliferative diabetic retinopathy, hypertensive retinopathy. Usually that's kind of more limited to the posterior pole. Ocular ischemic syndrome, also more limited to the posterior pole. Fewer, larger mid-peripheral dot blots. Radiation retinopathy, question mark. Leukemic retinopathy, question mark, in the sense that it can just have kind of diffuse hemorrhages. Sickle cell retinopathy, question mark.
Last week I had my first leukemic diagnosis. I had a diabetic with bilateral. She was mild diabetes. Now that she had bilateral retinal hemorrhages, swelling, just kind of funny looking. And then she was bruised. I said, "Anything else going on with you?" She said, "Well, I'm bruising. I just don't feel good." So I sent a CBC. I expected her to be anemic, and we got a call on Saturday that her white count was 267,000. So we sent her to the ER, and she's got CML. So it was
Saving
interesting.
eyes and saving lives, Dr. Cohen.
Once in a while, yeah, I know. You don't get that much every 30 years.
We're fortunate and unfortunate to take call at Moffitt, so we see a fair amount of this over there.
Okay.
I think I'm the only one who reaps the benefits because my kid goes to their daycare, which is really nice. Everyone else just suffers. Okay, so central retinal vein occlusion. It's an occlusion proximal to the lamina cribosa. Let me let someone in the house real quick. Sorry. Oh, hey. Come on in. Good morning. Chúc mừng năm mới. All right, sorry. Central retinal artery and vein share a common vascular sheath posterior to the lamina cribosa. If you have atherosclerotic changes and high blood pressure, you can basically compress the vein at the AV crossing in the sheath. The hypoxic retina releases VEGF and inflammatory mediators causing macular edema and neovascularization. Age is the most important risk factor. 90% of cases are greater than 50 years old. Hypertension, hyperlipidemia, diabetes, elevated intraocular pressure, and possibly smoking in younger individuals, hypercoagulable states. A lot of people bring up
Your
the
mic's picking up a lot of background noise. I don't know if
Yeah,
you're
let me
waiting.
wait a minute.
Okay. You can advance the slide, we just read it.
Sorry, we're celebrating the Lunar New Year over here, so it's a little noisy.
Yeah, it's exciting.
All right. People always talk about how like diabetes or obesity is a risk factor for central but not branch article. I think that's just stupid. And I think it was an artifact of the study because the pathophysiology is essentially the same thing. That never made sense to me. Younger people, younger than 30, look for hypercoagulable states. You want to divide these into ischemic and non-ischemic. The ischemic is perfused. Sorry, the ischemic is not perfused, and the ischemic is not perfused, and the non-ischemic is perfused. The non-ischemic is more common, 75% of the cases. The vision is usually better than 2200. They usually do not have an RAPD. There's a picture of one on the right. You can see tortuous vessels, dot blot hemorrhages, but it's not 360. And then sometimes these will resolve within 6 to 12 months. You'll get collaterals on the disc. And sometimes you can see a patient with collaterals on the disc and you can kind of infer maybe they did have a CRVO in the past. This may convert to ischemic CRVO. They say 30% in 3 years, but I don't know where they got that one from. They can have macular edema. The ischemic CRVO, it's less common, usually worse than 2200 vision.
Alex, if you do see discs on the nerve, if you do see vessels on the disc in an older patient and there's no vein occlusion there, it could have been an old vein occlusion. What's the other diagnosis you have to worry about? Do you know? Meningioma. So I had to scan somebody recently for that. It was negative, but yeah, I had a patient come in with the discs, nerve vessels on the disc, and it can be a meningioma.
A meningioma?
Yeah, on the optic nerve sheath. So it gets central vein occlusion 99% of the time, but I think you're obligated to scan them to make sure there's not a nerve sheath meningioma.
Okay.
If you did see the vein occlusion.
Poor prognosis, 50% will develop rubeosis iridis between 2 and 4 months. High risk of neovascular glaucoma. I think that was like the CVOS study. They called it the 90-day glaucoma. The retinal neovascularization is actually infrequent, which is interesting. I wanted to ask if anyone knows why you get neovascularization with the CRVO, but not a CRAO. Do any of the junior residents know?
Is it because the AO is so like ischemic to the retina that it basically kills the cells, so they can't even release VEGF?
Yeah, they basically die, so there's no more metabolic requirement for oxygen, so they don't secrete the anti-VEGF. Dr. Cohen, do you know why the anterior segment neovascularization is much more common than the retinal neovascularization?
No. I'm trying to think if I can think of that. I'm not sure why.
Yeah, because you think of other conditions where there's anti-VEGF and you get neovascularization elsewhere. You want to see these patients for 6 months, every month, to detect anterior segment neovascularization. Laboratory evaluation, you can get a blood pressure, CBC, blood glucose, cholesterol, cardiovascular risk factors. If they're younger than 30, you should get hypercoagulability labs. You have a protein C, S, or antithrombin deficiency, prothrombin mutation, activated protein C resistance, that's the factor V Leiden, lupus anticoagulant. It can be related to Behçet's, sarcoid, Wegener's, or good pastures, but I mean, that's less common. For
Now,
those
is there a cutoff for that? Because I had always heard 50.
Was
Did
it?
you- I've always heard 50 for the cutoff for working with.
You know,
guys-
yeah, but then if you have a patient who's 49 with hypertension, diabetes, and cholesterol, you're just like, do I order all these anticoagulants? I don't. My cutoff's 30. That they say 50, but you know, you see someone in the ED, they're 48. You're gonna order all this stuff. It probably
So
costs
just when
like
you do your
$5,000.
oral boards, just make sure your reference.
On your
for-
board, it's less than 50, but in real life, I don't know. My cut point is like it's a clinical gestalt. You know, do they have a history of blood clots elsewhere? Are they on OCPs? They have a family history of blood clots. But yeah,
One of the things about that always bothers me about the hypercoagulability workup is that you rarely act on it. So when you diagnose something, almost none of them, in the absence of a systemic clotting problem, almost none of these warrant treatment. The only thing I've read is that if you find stuff in a women of reproductive age, you usually tell them not to use oral birth control.
yep. You tell them not to use estrogen-containing OCPs.
But other than that, there's really not a whole lot of indication for treatment. It's just on a lab.
And a lot of these patients, I feel like they kind of know, you know, by the time you're like 46, if you have like protein CS and you haven't had a clot somewhere yet, I don't know, maybe you're not going to get one. I'm not sure.
Right.
So I think, okay, so for me, if it's 50 on the boards, but for me, if it's like less than 30, like it's malpractice not to order them.
Okay, thank
In
you.
the 40s, all right. Management, non-ischemic, 4 to 6 weeks follow-up, monitor for edema, or worsening ischemia. If it's ischemic, you know, monthly for 6 months, monitor for neovascularization with gonioscopy prior to dilation. 90 days is the highest risk for rubiosis. That came from the CVOS study. If the anti-VEGF is used, it actually might mask the iris neovascularization. So say if you're using anti-VEGF because they have macular edema, that could be preventing the iris neovascularization. So if you stop that, I feel like the clock almost like starts again. You got to kind of monitor them afterwards for rubiosis, even if, you know, they're now out of that 90 days. Macular edema, the anti-VEGF therapy is first line. You can inject and then monitor monthly to titrate the injection frequency. Intravitreal steroids are second line, but sometimes, you know, they're used, Ozurdex implants, things like that. And then neovascularization, panretinal photocoagulation. Even though I'm sure it's tempting for some in the community just to inject them every month.
So regarding the dilation issue, neovascularization, when you can see it on the iris of the slit lamp, yeah, especially around the pupillary margin, could be hidden if you dilate. But generally, neovascularization, the angle, won't be hidden by dilation. So it's really, you're looking at that iris just with the slit lamp before you dilate. You don't have to put the gonio on, lens on, at first, and that's helpful to know because you can get, if you put a gonio lens on, you can forget photographs. So, you know.
Yeah, my routine is monthly for 6 months undilated for central vein occlusions after you stop treatment or after onset for checking for rubiosis.
You should do the gonioscopy, but you can do it after you've done everything else.
Right, and I believe, and I don't think it's written anywhere that I know of, but I believe pseudophakics you have to worry about a lot more, just logically. For anterior, the lens seems to be a barrier. So,
The lens is a barrier, so is the posterior capsule.
right,
But if you have, you know, lost vitreous and have an anterior segment lens, you're gonna get rubiosis.
nice job, Alex, thanks.
All right. And then what happened to this patient? Lost a follow-up.
Yeah.